This conference will now be recorded.
Assalamu alaikum everyone. I'm Fizza Gilani and from Lincoln, Rhode Island. And sitting with me is Dr. Syed Iftikhar Hussain and my two very talented tech people, Ashar Hussain and Maya Hussain. And our guest speaker will be coming in a minute. He is Dr. Joseph Garland. Before that, can we start and every group just in 1-2 sentences introduce themselves?
Oh, I am Dr. Rizwan Naeem. I'm in New York and part of the team with Aziz Kumro and Fizza Gilani.
And Dr. Aziz Sumro, I will ask if you can introduce everyone. Dr. Aziz Sumro, can you please start introducing every group? Dr. Sumro, Dr. Aziz Sumro, आप प्लीज सबको इंट्रोड्यूस करवा सकते हैं डिफरेंट ग्रुप्स को?
I'm calling it.
I don't know whether he's listening.
Introduce everyone. We are online. Everyone is online.
Hello.
आप बेशक उर्दू में, सिंधी में, किसी भी लैंग्वेज में इंट्रोड्यूस करवा लें अपने ग्रुप को.
Hello. Hello, I am Dr. Moin Siddiqui. Can you listen me?
Yes, we are listening.
I am Dr. Moin Siddiqui. I am director of the Syed Abdullah Shah Institute of Medical Science, Seven.
Okay, very good. Thank you very much.
My institute is located in the middle of Sindh. It is a multidisciplinary hospital providing healthcare services at most 5 districts of the mid-Sindh. We are providing services on curative and preventive side also. Thank you.
Thank you very much.
My name is Dr. Nisar Sumro. I'm a consultant anesthesiologist, King Faisal Specialist Hospital, Riyadh, Saudi Arabia.
Thank you. Shukriya बहुत बहुत.
Dr. Maher, go ahead, introduce yourself. Dr. Maher. Dr. Maher, go ahead and introduce yourself, please. Okay.
Hello. Mr. Babar, can you mute your microphone? Mr. Babar. Mr. Babar.
Who is Mr. Baba?
Dr. Scott. Doctor.
Okay, everyone, can you please mute your telephone so we can start our speaker, so we can start our presentation? It's very hard to hear anyone because so many groups are speaking, so please mute yourself. So first of all, we want to say all views expressed in these webinars are of individual presenters and do not represent views of any institution. Number two, this is a volunteer project aimed to reduce stigma and increase awareness about HIV disease in Pakistan. No one is hired and paid by any institution to do so. Our group does not affiliate itself with any political, ethnic, or religious denomination. So the rules during the presentation are all computers are mute and only host and two co-hosts, which is Dr. Rizwan Naeem and Dr. Aziz Somru, will be on. So, and please write your questions in the right-hand side panel. And please ask questions relevant to today's topic only and keep them brief. Dr. Somru will handle the questions after the presentation. And our request, please fill out the evaluation forms sent to you after the webinars. So today's webinar is introduction from 12 to 12:05, and then Dr. Joseph Garland will be talking about HIV Care Cascade, and his discussion will end around 1 o'clock. After that, we will continue our HIV stigma provider patient communications, which we have been doing since webinar 1. So our HIV communication project overall goals are to reduce stigma and increase awareness about HIV disease by empowering healthcare providers with HIV disease knowledge and ways to improve patient, provider, and families' communications in Pakistan. So review of previous webinars. In webinar 1, we discussed very basic HIV knowledge and different aspects of HIV disease, including definition, and disease progression, stages, symptoms, and transmission modes in general and specific to Pakistan. We also discussed myths and facts related to HIV disease in general and specific to Pakistan. In webinar 2, our guest speaker, Dr. Phil Chan, discussed standards of HIV testing in general and in resource limiting settings. And he also discussed required lab testing for disease management and standard precautions related to HIV lab procedures. And last half an hour in every webinar, we dedicated to discussion on the importance of open communication between healthcare providers and patients about the HIV disease. So webinar 3, today we'll be discussing HIV Care Cascade, and Dr. Joe Garland will be talking about our own HIV clinic, outpatient HIV clinic in Rhode Island. So Dr. Joseph Garland, he completed his undergrad and medical degree from Harvard University and residency and fellowship training at the University of Pennsylvania. He is Associate Professor of Medicine at Brown University Medical School and is the Medical Director of the Infectious Diseases and Immunology Center at the Mariam Hospital in Providence, Rhode Island. He oversees the outpatient services of the Infectious Diseases Division, including the federally funded Ryan-White HIV Care Program and the Travel Medicine Clinic. He co-chairs the statewide 1990 collaborative for improving HIV outcomes in Rhode Island. So I'm giving mic to our dear guest, Dr. Joseph Garland. So.
Thank you everyone for having me. I wanted to sort of talk about two areas today. So Dr. Gilani and I work together, and there's sort of two areas that we thought I might be able to sort of at least explain what we're doing here. One is to talk about the HIV care continuum here in Rhode Island, and then sort of and with my role with the 90-90-90 collaborative. And then secondly, to talk a little bit about our clinic and sort of how we set up clinic, how we move patients through clinic, through my role just as the medical director of the clinic. So I wanted to start with the first subject, talking about the HIV care continuum, a little bit of background on global context, and then a little bit about sort of what we are doing here in Rhode Island. Many people have probably already heard of the HIV care continuum. It's also been called the treatment cascade, and it was something that was really first proposed in 2011 in a landmark paper in MMWR. And the investigators really tried to look at all of the different stages of HIV care. So trying to estimate the total HIV infected population of the United States, moving to seeing what percentage of that population has actually been diagnosed. In terms of the population that has been diagnosed, how many people have been linked to care, meaning they've ever been connected to care, and then how many people have actually been retained in care. Once you have folks who are actually retained in care, being seen in clinic regularly, how many people are prescribed antiretroviral therapy, and then our ultimate goal really is virologic suppression, because that is both important for the patient's health as well as from a public health perspective. We do know that people who are undetectable are unable to transmit to others, so it serves both the health of the individual and the health of society. And as you can see from the diagram from the original Care Cascade published in 2011, so disappointingly about 28% of the US population who was presumed to be HIV infected was actually diagnosed, linked to care, retained in care on antiretroviral therapy, and then actually made it to that last step of being virologically suppressed. The biggest step off, as you can see, really are between the second and the fourth column. From diagnosis to retention in care, you lose almost half the population, and that both in the US and globally remains the most difficult step of getting people from diagnosis to actually staying linked and getting linked and then staying retained in care. The key components of the HIV care continuum really can probably be boiled down to fewer columns, really looking at what percentage of the total population that's HIV infected is actually diagnosed, what percentage is actually retained and in care and treated and offered antiretroviral therapy, and then what population is virologically suppressed. That concept is really what led to the 90-90-90 campaign. It is an international campaign, as many people already know about, really led by UNAIDS, with the goal being by 2020, which I realize is very close, and may be revised to 2030, but 2020 of having 90% of all people living with HIV worldwide know their status. From there, 90% of that population who's diagnosed be engaged in care and be prescribed antiretroviral therapy. And then of that population, having 90% of that population offered therapy actually virologically suppressed. Again, that offers incredible benefit to the health of the individual, but also from a public health perspective to the risk of transmission across society. So how are different countries, different cities, different jurisdictions going about this? One of the major ways is through the Fast Track Cities initiative, from really launched by UNAIDS and the International Association of Providers of AIDS Care. We are part of that initiative, the Fast Track Cities initiative here in Rhode Island. So both the state of Rhode Island and the city of Providence have signed on to be part of 90-90-90. Which means that we have a statewide coalition of people saying, how can we try to get this, how can we get to this goal? Where we are in Providence are the numbers across the bottom. So we've actually reached 91% of the patients in the state, in the city of Providence diagnosed based on CDC estimates. About 79% are in care and offered treatment, and about 79% of those are on treatment. Of those who are offered treatment, about 91% are virally suppressed. You can see that even with all of our efforts, there's the biggest drop-off is really between those who are diagnosed and those on treatment. If you look at the population on treatment, 91% of those are virally suppressed. So if we get people engaged in care and on treatment, they get virologically suppressed. So that's where we are for the city of Providence. The 90-90-90 campaign, I think just to talk about, how much of HIV care is not just doctors and patients, but really, setting up a system for success. I think this is an example of that. So this is really, so I co-chair the 90-90-90 campaign with the director of the HIV division at the Rhode Island Department of Health. And the Rhode Island Department of Health is really pushing this initiative. As I've said a couple of times already, there is a very important public health goal of getting people who have HIV diagnosed in care and on treatment, both for their own health and for the health of the community in terms of reducing risk of transmission to others and overall community health. So the federal and state Rhine-wide programs are also involved. So the Rhine-wide programs, I should explain. So Dr. Gilani and I both oversee the Rhine-wide program here at the Miriam Hospital. It's a Rhine-wide program, is a federal program that provides federal assistance to clinics seeing people regardless of insurance status, ability to pay, or immigration status here in the US who have HIV. So we oversee the Rhine-wide program. So several health centers, including ours, are part of the campaign. And honestly, probably most importantly, several social service agencies are there, because if we think about the social determinants of health, if we think about the barriers to care of our patients, they largely, most people would rather be healthy than not, and they want to engage in care. And really the struggles that they have are, some basic needs around housing, around counseling, around mental health, substance use disorder, around transportation, making it how to get to the clinic on a very limited budget. So the social service agencies are really key in achieving 90-90-90. You really can't get there without these agencies coming together to support patients to get in the door. If they can get in the door with you, as you can see from our numbers, people generally want to take care of themselves, want to be on medications, want to be healthy, but there's so many sort of social barriers to that. There are patients also involved in the 90-90-90 campaign, because that's the key perspective is having individuals who are directly affected by HIV involved in policy setting and strategic planning for how to get to where we need to be. And then there are many others. There are folks from the housing department, from the state of health, there are folks from the city of Providence, etc. So that's sort of an overview of the 90-90-90 campaign for anybody who isn't already familiar with it on a global scale. And then a little bit of a local perspective about how we've brought the key players together and where we are currently. As you can see, we have not yet achieved 90-90-90 here in Rhode Island, so I am certainly humbled by the experience. We've been working on this for the last 2 or 3 years. Dr. Gilani pulls numbers. We are get better every year, but we are still not there. If that is helpful, that's sort of our perspective on where we've come. I also, we can have some discussions. So if you have any questions on that, I'll hold those thoughts or write it down. I also wanted to talk to you a little bit more concretely about our own clinic and our own perspectives from caring for a large urban HIV infected population here in Rhode Island. So this is really talking about our clinic, sort of with me wearing my hat as the medical director of the clinic. So just a reminder, this is a slide that Dr. Gilani has shared in previous presentations, really talking about HIV disease progression and stages. For those who may not have made it to some of the earlier webinars, just a quick reminder, if we sort of imagine on the left-hand side, a person before HIV infection, if you were to draw a blood sample, you would see, a regular normal CD4 count, you wouldn't see any HIV virus. At the time of infection, during acute infection, there is a large rise in viral load. People can have viral loads in the millions. And you get a usually significant drop in CD4 count at that time, while your immune system really struggles to reach a balance with this virus. Then there really comes a period of chronic infection, and there is a broad range of clinical presentations of that. Most people are asymptomatic. The average time from time of infection to AIDS to symptomatic disease is around 8 years, but that's very variable. There are rapid progressors who can progress from infection to advanced disease in a year to 3 years. And there are people who we call chronic non-progressors and elite controllers who tend not to progress even after a long period of time. But the majority of people fall somewhere in the middle in chronic infection, which over the course of years, the CD4 count gradually falls, as you can see represented by the decreasing number of white blood cells in the test tubes here. And the viral load gradually rises. It's not a passive process. This is sort of a constant battle being waged in the blood, that there's constantly virus infecting CD4 cells, lysing CD4 cells, producing more virus. Meanwhile, your immune system is constantly trying to produce CD4 cells. But over time, the total body CD4 lymphocyte count drops because of the cells are just being eaten up faster by virus than your body can produce. And eventually people end up in a situation where their viral load really is taking off and the number of CD4 cells present is low. Generally a CD4 cell count less than 200 cells per microliter is really what we look at for a diagnosis of AIDS. And that's really where you just have inadequate CD4 positive cells to ward off infections. If you remember, our immune system, and I'll say I'm a clinician, not an immunologist, so forgive my basic description here, but if you, imagine different components of our immune system are responsible for defense against different types of pathogens. Your CD4 cells are responsible for some specific pathogens, and when your CD4 count is low, you are at high risk, not for every disease, but certainly for many diseases that really require a CD4 response. So we commonly see pneumocystis and lung infections. We see cryptococcal infections. We see tuberculosis with advanced disease. So that's just sort of a quick reminder for anybody who hasn't been on the previous webinars about HIV progression. Our goal really is in the 90-90-90 initiative is with that first test tube example here, really to catch people before, so all the way over on the left here, to catch people before they get infected and try prevention. From time of infection, we really want to catch people as early as possible diagnostically. So in the next test tubes, we'd rather catch people during acute infection or during early chronic infection. The later the infection progresses, obviously, the poorer the health of the individual and the more risk that they will have had to transmit disease to others. So in 90-90-90, really that first 90 is getting people diagnosed. The second 90 really is to reverse the arrow. It really is to say we want to get people into treatment on medication. So rather than the natural progression to AIDS, we actually reverse it and send people back towards essentially where they would be here, where they still are HIV infected, but their virus is suppressed by the medication. So on a blood sample, you don't actually detect HIV virus. Their HIV test will still be positive, obviously, because they still will have antibodies, but their virologically behave like their virus will be suppressed, and their immunologically behave very similarly to people who are HIV negative and have good health. Okay, so a little bit of background on us. So the Immunology Center at the Miriam Hospital proudly serves over 1,800 people living with HIV, which is estimated to be over 80% of the population of people living with HIV here in the state of Rhode Island. So Dr. Gilani and I have the privilege of caring for the vast majority of the people in Rhode Island with HIV. Our clinic is staffed by 23 physicians, a nurse practitioner, and 2 physician assistants. That seems like a lot of doctors. Several of the doctors are researchers, so they don't actually spend a lot of time in clinic. That's why there's so many of us. But importantly, to my earlier point about really taking a community to care for people living with HIV, our team includes medical case management nurses, social workers who can really help with some of the barriers to care, a psychologist and a psychiatrist, because the reality is there's certainly a lot of comorbid mental health disorders with HIV. Having a mental health disorder puts one at higher risk of acquiring HIV just through potentially higher risk behaviors. And also just the diagnosis of HIV is a major psychological stressor for patients, as you can imagine. We also have patient navigators, so people living with HIV who can actually help our patients connect with our patients. And we have outreach workers, so people who can help with insurance, can help with sort of navigating how to get to a service agency. They come into the outreach worker and say, I'm having a housing issue, so what are the housing resources available, et cetera. And importantly, we have pharmacists, because there are some important drug-drug interactions, drug toxicities, et cetera, that we want to be able to be on top of. We are an active site for HIV research trials. Several of our faculty are on national boards, not me, but several of our research faculty are on national treatment algorithm guidelines. You're going to be hearing from some of them in future webinars. Just taking you to the path of the patient coming into clinic, diagnosis happens in the community the vast majority of the time. It can happen at the walk-in clinics, it can happen at STD testing sites. Across the state, the Department of Health really encourages testing at high-risk areas. So in the United States, there are certain higher risk populations, including men who have sex with men, sex workers, people who inject drugs. And so we offer testing at places where those individuals might come in for a visit or for anything else. So non-medical sites. When someone's diagnosed, they call the clinic, they speak to the nurse. We can usually get someone in for a same-day appointment or within the next couple of days, and that's important, linking people to care. If you remember the care cascade, the biggest drop in the care cascade is from people who get diagnosed to people actually getting connected to care and retained in care. And the longer people wait, the less engagement they will have. So we try to get people in as quickly as possible. They meet with our nurse. They get a lot of education about what's true and not true about HIV. They get their labs drawn. And some people will actually even start on medication that soon. So we really try to get medications in front of people as quickly as possible. Their first appointment with a clinician will usually follow within a week or two, at which point we review all the labs. And we really spend, I will say, I spend a lot of my time counseling patients. I have a slide on that coming up next just to talk a little bit about what we talk about. And I generally do try to start people on medication. Those of you who've been in HIV care for a while will probably remember this is a departure from what we used to do, which is we really used to wait for a certain CD4 count before starting medications. We used to look for signs of sort of needing to start medications. But both for the health of the individual, multiple studies have shown that starting earlier has important health outcomes, has a mortality benefit for people living with HIV, and for the public health perspective of decreasing transmission. So we really try to start people on meds as soon as possible. They follow up generally a month later to see how they're doing with medications, how they're doing with adherence. Adherence is a major struggle for particularly young people who haven't had to take a medication every day, so we really try to check in regularly around that. And then once people are doing stable, meaning they're undetectable, they're doing well on their medications, they follow up every 3 months. And then after a year, we actually usually move people out to every 6 months. The way our clinic is set up, patients are seen in the general infectious diseases clinic. And, I want to stress to all healthcare providers that this is sort of a message that we often have to remind our colleagues who are not familiar with taking care of people living with HIV, in our hospital system, that HIV is not contagious from any casual contact, and that so patients don't need to be separated into a separate clinic space. They are seen with all of our other general infectious diseases patients who are coming in for a hospital follow-up visit for their with their IV antibiotics, or who are coming in for treatment of Lyme disease, or coming in for treatment of hepatitis C or whatever. There's no special equipment, no special precautions needed. We see and examine them just like all other patients. We don't wear gloves. We don't have to wear any gowns. Casual contact is not a means of transmission of HIV, as you are all aware. In terms of when we do use standard precautions, that's around anytime we're using sharps, and anytime we're going to be potentially exposed to blood or body fluids. And by body fluids, I'm not including sweat, saliva, tears. As you know, those are not ways of transmitting HIV. So we use gloves for all phlebotomy procedures. We use gloves for all handling of blood and bodily fluids. We do not reuse any needles. We always use disposable needles. And we have sharps boxes. We have hard disposable syringe waste bins in all rooms, so that if you're drawing any blood, or if you are using a tongue depressor and if the tongue depressor breaks, you can have somewhere you can throw it away. So you really decrease any risk of anybody getting stuck and injured. At our initial visit, I usually talk to people about all the things I would talk to any other patient about in terms of getting a good medical history, current medication list, doing a physical exam. All of that is standard. I do it the same way as with any patient I would in the hospital or any other clinical setting. In terms of laboratory testing, I really confirm diagnosis of HIV. You had a talk from Dr. Chan last week on that. Check renal function is, I think, key, just because of the dose reduction needed in some medications, and other diagnostic laboratory testing. An important thing for all people living with HIV is assessing for co-occurring disease. So, we run an adult medicine clinic, and you'll be hearing from the pediatrics folks in the future. But in our clinic, assessing for tuberculosis, assessing for viral hepatitis, assessing for sexually transmitted infections is important, because there are diseases that tend to run with HIV, and those are those. So that's important. Non-infectious diseases, mental health, substance use disorder, et cetera, are also important. So we also do a mental health screen with all patients, both to look for pre-existing mental health disease, but also just for the psychological stress of a new diagnosis. I mentioned we have social workers and psychologists in clinic. They're key usually in the early stages of visits with people. We do a lot of patient education about HIV, which I'll talk about on the next slide. And we do a lot of patient education around treatment and adherence. The important pieces are pretty self-evident. Take the medication as prescribed. You have to take it every day. Unlike a blood pressure medication, missing a couple of doses of a blood pressure medication, in theory could be life-threatening, but generally isn't. The difference with HIV is we're actually treating a pathogen that can change and can adapt to antiviral exposure. So if you stop medication and restart it, as you know, patients have a high risk of developing resistance. And with limited treatment options, we don't want to have to move them to second line and third line regimens. So adherence is sort of a key component of all HIV visits. We consider starting treatment on the first visit, as I said. And we schedule a follow-up usually in a month. When I talk to patients about their education, about sort of education around HIV, it's sort of tailored to each patient based on where they're coming from, what they already know. So I usually try to start by asking people, what do you know about HIV? Tell me what you know so far. I think that if they have someone that they have disclosed their status to, I try to bring that person into the room. Sometimes it can be overwhelming to one person to remember it. Sometimes it's helpful to have someone else there. If there's a spouse, it's actually really helpful for the spouse to really understand what the risks are and aren't. I think fear drives people to overestimate their risk in the wrong areas and underestimate their risk in other areas. And you know, people who don't have medical backgrounds sometimes will look to the internet and sort of end up getting incorrect information, because there's a lot of really useful resources available through the internet. There's a lot of incorrect information on the internet as well. So I talk about that. I really focus with people that HIV is not a death sentence. People still have that idea in their minds even today. With treatment, people living with HIV have a normal life expectancy. I counsel people that any plans that you had made for your future, I would hold on to them. Those are still our plans moving forward, including if you want to have children, etc. There are things we need to talk about, so don't go out and try to do that immediately. But people living with HIV certainly can have can have children and can have a normal life expectancy. We talk about getting on treatment. Again, as I said, both for the individual and for public health perspective, getting on treatment is important. So treatment improves morbidity and mortality at any stage of disease for people with HIV. Treatment is prevention. And the sort of campaign here in the US is U equals U. So undetectable means untransmittable. People who are on meds and undetectable can't transmit virus to others. We talk about how HIV is transmitted, so blood to blood, for example, needle sharing, sex, maternal to child at birth, and breastfeeding are the main ways that I talk to people about how HIV can be transmitted to others. How HIV is not transmitted, I think, is important, particularly if there's a family member or spouse in the room. That HIV is not transmitted in saliva. You can't get it from kissing people. It's not transmitted in sweat, tears, urine. Really, the body fluids that we talk about as causing transmission are blood and fluids exchanged during sexual activity. Casual contact, hugging people certainly can't give you HIV, and you can't get HIV from public facilities like toilets, swimming pools. It is not transmittable by mosquito. It cannot survive in the mosquito. Skin-to-skin contact, etc. So all of these are ways that we as healthcare providers know, but that people living with HIV, who particularly newly diagnosed, who feel sick, feel like they are contagious, need to be reassured that they don't have to eat off of separate plates. They don't have to drink from separate glasses. They can still hug their children, their spouse. They can still kiss their loved ones, and they are not giving and transmitting any risk to others. In terms of treatment decisions, these are very location dependent. The US generally follows the Department of Health and Human Services recommendations, which you can look up online at aidsinfo.nih.gov/guidelines. So this is what Dr. Gilani and I use in our clinic. We are required to because of our federal funding. And I will say that the US guidelines are not particularly that different than the current WHO treatment guidelines, which were released at the end of 2018. Really looking as a sort of interim guidance, focusing on shifting first-line therapy to integrase inhibitor-based regimens. It's probably more than the scope of this talk to go into that extensively, but I just want to show you those are the guidelines, which are also available online from the WHO website, and the guidelines focus, you guys can see my arrow here, but focus on for men in general trying to offer tenofovir plus tenofovir plus lamivudine or emtricitabine with dolutegravir, which is an integrase inhibitor. Alternative regimens, tenofovir plus lamivudine or emtricitabine with efavirenz, and then in some situations, AZT, lamivudine, and efavirenz. I believe from what Dr. Gilani has shared with me that integrase inhibitors are not widely available in Pakistan right now. So most people are probably using either this alternate first-line regimen here or the sort of special situations regimens based on drug availability. But looking to the future, dolutegravir is actually generally relatively inexpensive and has a very high barrier to resistance, very good tolerability. So it's an excellent treatment choice. If that can become available. And there are over 80 countries around the world that have moved to using dolutegravir-based regimens. So the US and Europe, Australia, and New Zealand generally, most countries have, in terms of countries in the developing world, Brazil, Botswana, Kenya, several other countries have moved to dolutegravir-based first-line therapy. There is a warning around dolutegravir in women who are of childbearing potential, and Dr. Kuvan will talk a little bit more about that coming up. But that's probably going to go away depending on the results of the upcoming study that's just concluding. You'll actually have a talk specifically on care of women. I think I know people have actually put some questions up, so we'll try to get to questions in a second. Again, I'm not going to go too much into treatment. I would say that the important things to think about are what is your sort of standard go-to treatment regimen? What are situations in which you'd want to do an alternative, and what is that alternative? And then sort of the important thing is what is your second-line regimen? In most places, there are standard sort of first-line regimens and second-line regimens, and in these same guidelines, there's actually WHO guidelines for standard first-line regimens and standard second-line regimens. So I recommend the WHO guidelines to folks, and I apologize I didn't put the website on here, but we can put that on the next set of slides. All right, I think that's sort of the background on stuff that that Dr. Galani had asked me to talk about. I know that folks probably had some questions, and I saw a bunch of questions sort of flash up as I was talking, so we can try to go through those. Let's see. Let's see. Down to which direction does it start? Okay. So TB is very common in our society. So I'll just read out the question and then try to respond. So TB is very common in our society. Should we consider like every patient having, or HIV patient having TB until proved otherwise? Oh, do they want to see me talking? Yeah. Oh yeah, sure. Hold on one second. We'll switch so you guys can see me on the webcam. All right. Hopefully folks can see me here. I can't see myself, so please, somebody message me if I have something hanging off of my face. So the question was, TB is very common in our society. Should we consider every TB as having HIV until proven otherwise? That's an interesting question. I would say that yes and no. I would, from the perspective of should everybody diagnosed with TB be tested for HIV? Yes, that is something that in general is recommended because people living with HIV have such a higher risk of having tuberculosis. So if you diagnose someone with tuberculosis, yes, I would recommend testing them for HIV. I would not necessarily assume that they have HIV, meaning I wouldn't send additional labs or start them on therapy, et cetera. But yes, I would recommend diagnostic testing in all people who are diagnosed with tuberculosis. And in areas with high tuberculosis endemicity, all people living with HIV, the WHO does recommend screening for tuberculosis. And there are actually guidelines on starting people on isoniazid therapies actually for people who do not have tuberculosis. In high endemicity countries of actually starting them on isoniazid therapy as prevention. Okay, if you have more questions on that, please feel free to just throw another question up there. I'll see if I can scroll through these. I apologize. Down. Our society does not have a well-built GP system like any Western countries. I will say that is not uncommon. So I have not worked in Pakistan before, so I can't speak directly to suggestions for you around that. Dr. Galani probably could offer something. I've worked in other settings, including my mother's from Thailand, so working in Thailand, and then in Botswana and Kenya, and for example, Botswana, which has a has a large HIV epidemic, really built the HIV system sort of separate to or parallel to a primary care system, and really offer GP services sort of wrapped into the HIV care model. So they have a clinic where people come for their HIV care, but while they're there, they get their gynecologic screening, they get their blood pressure treated, etc. That's actually what we do at the immunology center here as well. So many of our patients actually get their primary care in our clinic as well. So though we treat their HIV, we also serve as their GP, and then we treat their diabetes and their hypertension. It actually makes a lot of sense because there are important drug-drug interactions. There are toxicities to the meds that we would recognize as HIV providers that a GP might not. And sometimes the fractured care of having multiple people engaged can actually, or multiple providers engaged can actually be a detriment to patients. So I would say I wouldn't see that as necessarily a barrier of not having a GP system set up. The HIV clinic can serve that role, and there are models both here in the US and in countries around the world where that actually works really well. And I'm a big supporter of that in general. Which virus is considered more risky, HIV or hepatitis? So it's interesting. In terms of transmission, sort of risk from a needle stick injury, far and away the highest risk is hepatitis B. And I can't remember the exact numbers, but I think it's if you have a needle stick from someone with hepatitis B, you have up to a 30% risk of actually acquiring that from that needle stick. HIV, so hepatitis, viral hepatitis, hepatitis C is actually higher risk, the next highest risk for transmission, but it's much, much lower. It's around 3% from a single needle stick injury. And then from HIV, I think is around 0.3%. And in terms of, so for someone getting a needle stick injury, you'd be most concerned about hepatitis B, second most concerned about hepatitis C, and least concerned about HIV. It certainly does occur or has occurred, but it's actually very, very uncommon for injury to the provider from that.
Some of them cannot hear.
Oh, I'm sorry. I will come closer. In terms of risky from a patient perspective of having those diseases, that's a more complex question about, I'll say HIV makes hepatitis B and hepatitis C worse in terms of disease progression, risk for cirrhosis, risk for hepatocellular carcinoma. All of those rise with HIV co-infection. In terms of which of the three it is most likely to progress to disease or have the most morbidity associated with it, I don't know that I could give you a fair answer to that. I would say that treated HIV would be the lowest risk, but untreated HIV versus untreated hepatitis C and untreated hepatitis B, I don't know I could give you a fair answer on that, sorry. On average, how much would the cost to treat one patient having diagnosis of HIV be, please? So I actually can't give you a fair number for this because it's very country dependent. Yes. So in the US, yes, so Dr. Gilani is right. In the US, it's $36,000 per year. That is not true outside the US. Drug costs in the US are like in a world of their own, as I'm sure you're aware. And I don't have in front of me the numbers from the WHO. It is something that is treatable and that is doable in countries across the resource spectrum. In countries that are of more limited resources, there are certainly global fund funds, there are PEPFAR funds, there are many different sort of international agencies that provide funds for treatment. But yeah, even many countries in Africa that really have very limited resources are able to set up HIV treatment programs using their own public health funds, largely because of availability of low-cost treatments. The U.S. is its own sort of world with drug costs. How much would it cost in U.S. dollars to perform one test to diagnose HIV? Do you know that? An HIV test, how much an HIV test costs in the U.S.? I mean, it's free in the U.S. In terms of the cost of the test itself, it's not very much money to the healthcare provider, but we have free testing all over the country. So to the patient, it's free. In terms of the cost to the providers, it's a small amount of money.
This is Dr. Rizwan Naeem. I'm involved with HIV testing, so I can answer that question.
Excellent. I will refer to you.
Right. So if you are looking at immunological-based testing, which is antigen or antibody or both, your cost in US is not more than $5, $4 to $5. But
Thank you.
if you're looking at viral load testing, which is for maintaining dose and monitoring the disease, it's cost about $50, $50, $45 to $50. That is the cost to the labs. But what insurance companies are charged, very different. What patients have to pay, very different. But that's the cost of these two different type of mainstream testing. Thank you.
Thank you. And that's an excellent point. And I will say viral load testing is part of the US treatment guidelines. Following viral load is not part of the general WHO guidelines for most settings. People really due to cost and wanting to look at sort of a public health perspective of distribution of resources. So we do use viral load testing here in the US, but again, it's not something that is actually necessary in most treatment algorithms. Next question is, what standard precautions do you take in HIV clinics, and what advice do you give family members and caregivers? So I talked a little bit about that on a couple of slides ago, but in terms of standard precautions, we see patients in clinic just like any other clinic. There really are there's no isolation precautions at all. We see patients, we don't wear gloves when we examine patients, other than obviously something you would normally wear gloves for, gynecologic exam, obviously. But if you're just listening to people's heart and lungs, we don't wear gloves because we know that there's no transmission from casual contact. In terms of what we call universal precautions in the US, as I said, that's really when you're dealing with something sharp, like a needle, and it's when you are going to be exposed to blood or significant body fluids, not including saliva, sweat, or tears. What advice do you give family members and caregivers? In general, we tell people living with people who have HIV that they don't need to have any change in the way that they live together, other than the risk, being aware of risk exposures being blood. So if the person with HIV bleeds, you would want to make sure you use gloves to clean it up. And sexual activity. So we do tell people not to share things that would potentially be contaminated with blood, like sharing razors, for example. But in terms of daily activity around the home, there really isn't an exposure from casual contact. There isn't any exposure risk from casual contact. Eating around the table, sharing plates, sharing utensils, sharing cups, sharing dishes. There is a wealth of research around this, and it is not possible to transmit. So sharing a bathroom, sharing a shower, any of these things, it's really blood and sexual activity for family members. Anything else you wanted to add?
Yeah, I just wanted to, if you could.
Oh, how would you protect your staff? That was another question that came up. And how would you train your staff? So in terms of protecting the staff, I think that it's, the staff, it's the same as us. So our phlebotomist, if someone is drawing blood, if our nurse or phlebotomist is drawing blood, they should use gloves. They should have a sharps container within reach of them, so they can, when they're done drawing the blood, they can put the needle immediately into the sharps container. So there's no risk of a needle getting lost in the sheets that they then, stick themselves on later on. But it's sort of the standard thing that you would use anywhere. You would do in any time when you're drawing blood. So gloves for anyone who's drawing blood. Sharps box is available in all the rooms, so if you get something sharp, you can dispose of it immediately. But our staff don't wear gloves. Our staff don't wear, we hug patients. That's all very standard. The training of staff is important because, as we talked about, people who have less medical training than healthcare providers may not be aware of that, of the ways you can and can't get HIV. And anytime we have new staff members, we do sit down with them and really talk to them. We talk to them about respect for the patient. We talk to them about how important it is for patients to feel, like they aren't contagious in the clinic, that they're not putting anybody at risk in the clinic. So it's important to talk to staff about ways you can be exposed to HIV and ways you can't. And so that staff know, and it's actually not a hard algorithm. Like, sex is not really, a part of the clinic encounter. So it really is just blood and body fluids. And most people who work in healthcare settings can sort of conceptualize that and understand, these are the ways to protect myself. How do you deal with an accidental needle stick injury? So that's a key one. And that's a hard one. There are actually standard what's called post-exposure prophylaxis guidelines, the general idea behind post-exposure prophylaxis is that if you are exposed to HIV, you want to take an HIV treatment medication for a period of time to prevent you from getting HIV. And post-exposure prophylaxis, if you know the patient has HIV or if you're unsure, but they might, is basically to take the first dose of the antiretrovirals right then. Post-exposure prophylaxis guidelines in general are, in the US, are Truvada plus dolutegravir, so tenofovir plus lamivudine or emtricitabine plus dolutegravir, same as first-line HIV treatment is, for 28 days. The staff member should be tested for HIV to make sure that they don't already have HIV, because you don't want to treat them and then stop. And you generally do need a creatinine, just like if you were treating someone who had HIV, those were the pieces you'd want. Obviously, it's very traumatic for staff members, so you want to do some psychological counseling. You want to treat them for 28 days, and then you want to retest them at a month, and then 3 months afterwards. The biggest thing I can emphasize to people is that it is extraordinarily rare for people to get HIV from a needle stick injury in a healthcare setting. In fact, in the United States, since the implementation of post-exposure prophylaxis protocols, there has been possibly one in the last 10 to 15 years, a person who actually did get HIV from the exposure. Everyone else, all of the thousands and thousands of other needle stick injuries, no one else got HIV. So if you have an ability to set up a post-exposure prophylaxis protocol in your clinic, educate your staff and yourselves on it, that is a very reassuring thing to have for anybody who gets an accidental needle stick injury, and you can say your chance of acquiring HIV from this needle stick is almost zero with this protocol. Again, I apologize, I don't know that your ability to set that up in the clinic setting, but that is something that we do standardly here in the US. Okay, a couple other questions. Can an individual having HIV get a job? Will it preclude from getting a job? In general, no. So there are a lot of legal protections in the US about, patients' right to privacy and sharing patients' information. But I generally tell people that there are not many jobs that you can't get with HIV, particularly if you're on medications, because there are not that many jobs in which you would expect, high risk of blood exposure or sex exposure. So they probably should not get a job as a sex worker. They probably should not get a job, donating blood. But outside of those situations where there would be clear, exposure risk, casual contact is not a reason for people not to be able to work. Most of my patients work. I have patients who are physicians, who are healthcare providers and see patients. Different hospitals have different protocols specifically on surgeons and people working in the OR because of a potential higher risk there. But that doesn't necessarily preclude people even from being surgeons, although that is a sort of a special category that really depends on the hospital and the clinical setting. But almost any other job, working in a store, working in a restaurant, working as a chef, that I have patients doing all of those. That is not a way that people can transmit HIV. So yes, people should definitely get a job. If any healthcare provider gets an accidental needle injury from a patient in hospital, what should you do immediately? So that was actually just what I just talked about. The most important thing, I will just add to that post-exposure prophylaxis protocol, is time. So the PEP has been shown to be effective up to 72 hours afterwards, and most effective within the first hour to 24 hours. This is not something you can do a randomized controlled trial on, so we don't have really solid data, but it seems to be good up to 72 hours. But the most important thing would be obviously wash the wound out thoroughly,
basic first aid protocols, take your first dose of post-exposure prophylaxis, and then deal with checking the renal function of the person who got exposed, checking the HIV status of the person, of the patient who exposed the staff member, and then deciding whether you need to continue the protocol or not. Is there a vaccine against HIV infection? Unfortunately, no. There are a lot of studies going on to try to find a vaccine, but we do not have a vaccine available against HIV infection. There is also no vaccine against hepatitis C, unfortunately, yes.
problems in Pakistan is we do not have well-developed insurance system. So I agree. I mean, I'm not sure that we have the most wonderful insurance system here in the U.S. And Dr. Galani and I take care of a lot of people who have no insurance as well. So I would say that, you know, really thinking about HIV from a public health perspective, what are the systems we can set up in terms of are there public health clinics that can care for people living with HIV? And that is something I'm sure people are looking at. Without insurance, the drugs are expensive, and most people cannot afford them in the U.S. Even in countries where the cost is lower, people often can't afford them. But not having a fully developed insurance system does not preclude having a good HIV treatment system. Many of the patients we care for in our clinic, I think 28% of the patients in our clinic are foreign-born. Many of them don't have access to U.S. insurance systems, so we see them through our federal program. Can a human with HIV transmit infection? So in general, so yes, the way people get HIV is from other individuals, but really only from the ways we talked about: blood exposures and sexual exposures. I'm sorry. Dirty needles. And dirty needles, right? So reusing needles. So if there's blood, even if it's microscopic, if there's blood in the needle from drawing from one person, you go to the next person. The first person has HIV, you can transmit to the next person. There's a separate talk on this, but you know, maternal child transmission through childbirth and breastfeeding is another possibility. If I get a needle injury from a patient who is suspected of HIV, do I have to get his or her consent for testing? So that is actually, something I'd have to defer to someone in Pakistan, because I don't know the legal system there. Here in the US, it's very state dependent about testing. If a patient declines testing and we are not allowed to get them tested, we do still have the post-exposure prophylaxis protocols that we know are effective. And so if we can't confirm an HIV negativity in a patient and we're worried they might have HIV, we do the full 28 days of post-exposure prophylaxis with the healthcare provider that got exposed. And that way we're protecting that provider. Okay, I think that was all of the questions on the list. I'm happy to take more questions.
Thank you very much, Dr. Garland. And now our protocol is we will give this speaker to Dr. Aziz Sumru, and he will give chance to one person from each group, please. I know there are many people trying to introduce their protocols, their institutions, so please one person from each group. And a small comment on Dr. Garland's 90-90-90 campaign is like, if you start thinking about Pakistan, I think we are on other side of the spectrum, 10-10-10, but we are starting now, and all of us together we can make more development in this and can achieve this goal in a few years. So Dr. Aziz, can you start introducing one group at a time?
Hi, Dr. Garland. This is Dr. Sumru from New York.
Hi, Dr. Sumru.
Yeah, so I'm going to introduce Dr. Sikandar Memon. He is in charge of the HIV program in Sindh. Dr. Sikandar. Dr. Sikandar, go ahead.
Assalamu alaikum.
Dr. Sikandar, just 1 minute, please. Give us a minute.
Yeah, you have to unmute yourself.
Can you please unmute yourself? Dr. Aziz, we cannot hear him. Can you please tell him to unmute his phone, his computer?
Okay. Assalamu alaikum.
Yes, now
Assalamu
it's
alaikum,
fine.
everybody. Thank you very much for arranging this very useful and informative session for the doctors of our community, province, who would be able to give their treatment to the patients as well as give information to the general population, which is now suffering a lot, because initially it was a disease of a key population, that is called high risk population, but nowadays the emerging situation is alarming for we people, and it is in general population. And out of 25,000 people, we have 750 cases positive. Out of 750, we have 600 children. So I would must thank to Dr. Aziz and other all stakeholders who are sitting and viewing this all. The people who are available in Sindh at LUH Hyderabad and Gambat, Larkana, everywhere, they all are requested to please gain knowledge from the senior clinicians who are available on the webinar, and giving us a lot of information about the patients during treatment and other things, preventions. And please participate in the community, because this is the need of the time to go in the community and aware them. And there is a big fear in the community that if this fatal and dangerous disease is coming in general population, people are very much worried. So besides our community workers, community health workers, and some of the volunteers, NGOs, we need support of the doctors who are clinicians treating the patients, particularly pediatricians. They all are requested to make awareness among the community that there is no danger if someone is kept on treatment and he's continue with the treatment for long life. So their motivation and awareness among the community will help us a lot. And I would suggest Dr. Aziz that spread it across the province. I will help also, because I have been asked by my secretary to ask every teaching hospital and district hospital to be available on webinar from next session. Inshallah, I will make my all efforts to make available all the doctors on webinar on district level basis. Thank you again. Thank you again. I'm very much thankful to everyone.
Dr. Moin from the 7, please. He is in charge of Abdullah Shah Institute of Medical Sciences. Dr. Moin.
He has to unmute himself.
Dr. Moin, can you please unmute yourself?
Dr. Moin, can you hear us? Okay, I will go ahead to the Larkana Center. Dr. Murtaza is an ex-Vice Chancellor of Benazir Bhutto Medical University, if he has any question.
I'm Dr. Shantilal, a pediatrician from Shahid Mohtarma Benazir Bhutto Medical University. I have a question to the speaker. Can you suggest that, because HIV is now epidemic in our area where every pregnant mothers, children, even adults are suffering from, can you give us 1990 model to our area so that we can control and early detection and treatment of the cases?
Sure. Let me unmute myself here. Well, I will say that the way 90-90-90 happens, or the way to implement 90-90-90 is different in different situations. I will say that if one thing that I think would be important in given the particular situation that you have described is making sure that all pregnant women are do get testing for HIV, both for their own health and because of decreased transmission. Women who are treated for HIV, pregnant women who are treated for HIV, if they get undetectable by the time of delivery, generally do not transmit HIV to the infant, and that obviously makes a significant benefit to the life of the child and to the future of the family. How to get to 90-90-90? There's sort of those three. I'll say, obviously, we haven't done it here in Rhode Island yet, so I can't give you the magic way. But the first piece is sort of getting a sense of the scope of your patient population, so testing. And really, I think that one of the other physicians earlier pointed to an important change where this was, previously in high-risk populations, and now we have are see more in the general public. And so thinking about how you can implement more widespread HIV testing campaigns and figure out are there different risk factors occurring in Pakistan than there are here, for example. And I don't know enough about the background of the situation, but was there vaccination protocols that would have included sharing needles that might have potentially exposed more children, or et cetera. So figuring out what the new risk populations are and making sure you have broad diagnostics, testing campaigns, because that's really the first 90. You want to get 90% of the presumed infected population diagnosed, because if they're not diagnosed, they're not going to get anywhere further on the spectrum. So it sounds like the stage you guys are in really would focus in on that. But then you have to be prepared to do something when you have someone who's positive. So what we have learned in our campaign across the state, Dr. Gilani and I, has really been having to set up sort of networks. So social service agencies that are willing to work with people living with HIV, and clinics that are able to accept them. So when you have someone with a new diagnosis, you can capture them before they're lost, out in the world. And that really is what gets you to the second 90 and the third 90. I guess the third 90, also figuring out some standard treatment algorithms. There may already be a Pakistan-wide standard treatment algorithm for standard first-line therapy, standard second-line therapy. But if not, the WHO has good models, and many countries have published their treatment guidelines based on what drugs they have available. And based on the list of medications you have currently, you certainly have medications for standard treatment first-line regimen, and should focus in on getting some drugs available for people who might need second-line therapy. I don't know how much of an answer that was, but I would say testing campaigns, and then setting up both social support systems and clinics to have a way to capture people once they're diagnosed.
I will, Dr. Sumro here, I will give a chance to Gumbert Institute of Medical Sciences if they have any questions.
Thank you so much. I am Dr. Shamim Bhatti from Gumbert Institute of Medical Sciences. No question yet. Thank you so much.
I'm sorry.
Dr. Shamim, we cannot hear you well.
No question yet, madam. Are you hearing me?
Yes.
Yes.
Thank you so much.
Yes, Professor Murtaza Pathan speaking, and I appreciate the efforts of my colleague and son of soil of this area, Dr. Aziz Sumro Saab, and he make the efforts regarding the crisis in this population. And I also want to share the experiences of such type of outbreak in the world, so we can benefit from their experiences, because the crisis is that the people fear regarding the disease. We need the efforts, inshallah, in near future. Dr. Aziz Sumro may submit regarding the psychological issue, and also in near future the next session, the treatment. So I thank Thank you, my colleague and other who participate in this program. And inshallah, in next session, we also benefit from the further benefits and information regarding this issue. So thank you, Dr. Aziz Sumro. I hope that you will also further share regarding the issue and help to solve the problem at the yet which we facing in this crisis. Thank you very much.
So this is Dr. Rizwan Naeem. I also want to introduce another very important team member from the United States. His name is Dr. Hamid Jafri. He is an alumnus of Sindh Medical College, and he is one of the directors of polio program from CDC in Atlanta. He's online, and I would like to ask him a brief question. As you may all know, that there is a team of CDC and WHO in Islamabad and now in Sindh also investigating this crisis. So if Dr. Hamid Jafri, could you please unmute yourself and say a few things, what's happening with the CDC team and WHO team and how we can help, especially the people on the ground.
Dr. Jafri, can you please unmute yourself?
Hamid, did you, Dr. Hamid Jafri, did you hear my question? Dr. Hamid Jafri, can you hear us? Hamid is online and he's replying me back. There might be some technical issues. One of the operator, I think one of us need to unmute him. He said the operator need to unmute me. So Iftikhar and Fiza, can you please see and unmute him?
Yes, we are trying. Yeah, just a minute.
We don't see it yet.
Okay, hello. Can you hear me?
Yes. Now we can hear
Okay, assalamu alaikum, colleagues. So this is Dr. Hamid Jafri. As Rizwan mentioned, that there is a team of WHO experts that arrived in Karachi earlier this week, and that team includes 2 experts on HIV from the HIV program here at the U.S. Centers for Disease Control, and they are on the ground to take this investigation of this outbreak to the next level after the initial investigation that was done by the FELTP program. I'm sure Dr. Sikandar from the Sindh HIV control program is working closely with them. They've just arrived, but we are already hearing important details. And I think one of the challenges, as you may already know, is with the availability of appropriate HIV testing kits and the testing protocol. So I think one of the areas that CDC and WHO would be looking at together is the to making sure that the appropriate standardized testing material is available to Pakistan. And in fact, at CDC, they're looking at emergency procurement of some testing kits to make sure that the testing continues in a standard manner. I think the other outcome of this investigation, of course, we are looking forward to is a much better understanding of the risk factors and the source of this outbreak, so that the preventive measures can be appropriately taken and targeted, not only in this area of Larkana, but in fact more generally across Pakistan. And thirdly, of course, there is going to be a lot of aspects that were being discussed just now. I'm very thankful to the Brown University experts and Rizwan for the kind of education that they're imparting on treatment of that would be necessary for the affected children and the general population, and setting up the program for the 90-90-90 targets, I think would be, of course, very important. And most importantly, I think we will need a very sophisticated and intense approach to handle the challenge of stigma in the community. That really has to, because I think it affects families, it affects healthcare providers, everybody, and we need to really destigmatize the situation very rapidly. What I'm going to do that after we have, after the team has been on the ground for some time and are starting to reach their own conclusions, I would like to connect this webinar team with the WHO and CDC team so that there can be a common approach to training, common approach to how we can support our colleagues and clinicians on the ground in Sindh in managing this outbreak. Over from my side. Thank you.
Thank you very much, Ahmed. That will be great, and we will love to join the teams.
Absolutely.
Thank you, Dr. Ahmed Jafri.
Dr. Garland, Dr. Sumro is from the King Faisal Medical University in Saudi. He has a question.
Well, thanks, Dr. Joe Garland. It has been an excellent presentation along with improving our knowledge regarding this important topic and the outbreak of this disease in Sindh, particularly in Larkana. Certainly, it will improve our knowledge and understanding, and the public will be brought into more awareness of this program. Hopefully, local agencies, along with support from international agencies, they'll help to improve the diagnosis, treatment, improve the quality of our community. Thank you very much.
Thank you.
Yeah. It's a question from Mr. Tarshe about please develop a flyer in Sindhi. We will try our best. We will create the flyer in English and Urdu, and then we will send that to Mr. Sumru or someone in Larkana so they can translate that into Sindhi. Thank you very much. Dr. Sumru, Aziz Sumru, is there any other group want to join? Cast him unmute. Dr. Sumru, can you please unmute yourself? Aziz Sumru. Is there any other person?
I think he's paused for some reason. I'm calling him.
Okay. Is there any other question from the audiences?
Hello, Dr. Garland. I am Dr. Penwar from Saskatchewan Cancer Agency here in Regina, Canada. I have a question. Sorry. That in Sindh, the used syringe is a common problem. Our general practitioners, our healthcare provider in rural areas, they use the used syringe, and then they throw it out, and then these are collected by the people and sold for factories, and they again just clean them or wash them and put them in a market again. So my question is that for how long, suppose a syringe from HIV patient, for how long the virus can be survived on that needle?
Oh, in a syringe? It's a good question. It's a good question. I don't know that I can give you a great answer on that. The HIV virus can't survive too long outside the body. A higher risk is actually from hepatitis B, which can last a very long time.
and hepatitis C. HIV can't last that long outside the virus, but I would imagine, and I don't want to quote you an exact number because I don't have one I don't know one off the top of my head, but I would think a couple of days. I think that the issue with transmission from syringes is threefold for the HIV, hepatitis B, and hepatitis C, and then secondly, but in terms of the issue of transmission, it's probably from immediate reuse of syringes more than a syringe that's been sitting out for a long time. I can't give you an exact amount of time, so I don't want to speak out of turn there. Lance, do you happen to know?
So actually, what I heard,
Yeah.
Yes.
that they actually, sorry, this is Dr. Hussain. So what they actually do, I've heard that they have a 10 cc syringe with the same needle. They give an injection to the kid 1 cc each. This is what I heard. And number two, on the same day. And the number two, they are not using a clean instrument for circumcision and also body piercing. And they are not using the clean. On the same day, they are using the same instrument on the patients. I think, and also the other thing, to the kids, if they had 1 liter of glucose bottle to give kids, they gave 250 cc of IV fluid to one kid with the same needle they go to the other places, to other kids. That is where I found out. In old ages, they used to give injection in the army like 50 years ago with the same needles, and in developing countries, they are still using the same technique.
My guess is that's a high risk. You know, a syringe that has been discarded and it's been several days, the risk of HIV from that needle is very, very small. It really is, again, hepatitis C and hepatitis B, but I think that the immediate reusage is, as Dr. Hussain alluded to, is probably the high risk that potentially could be part of what's going on here. Again, we don't know. That's what the CDC and local officials are looking at, but that would be, I think, what everyone is worried about. I don't know. What is your perspective in Saskatchewan?
No, in Saskatchewan, you know, in Canada, there's no issue of the EU syringe, so I don't have local experience of this here. I'm just talking in the perspective of Sindh and Pakistan.
Yeah, no, it's a fair question. I'm sorry, I don't have the exact answer for you.
No, thank you. I understand. Yeah.
So Dr. Sumru, Aziz Sumru, do we have any other group here? So if there's no other question, then we will talk next Sunday. Our plan is to do HIV treatment, and I think most probably Sunday will be on pediatric HIV patients, and then next Sunday will be on pregnant women and adults. And we will try our best to include all of your questions. So please, and I just have a request from Mr. Maiman. If I can get a list of all medications which are available in different hospitals for pediatric as well as adult HIV children, I will send that list to my colleagues, and then they can design or they can suggest the treatment options for you. And please prepare your questions for next week treatment sessions. And we are sending an evaluation form to every one of you. So please, it takes only 1 minute. Please fill it out and send it back to us. That is our way to collect more information and need assessment. Thank you very much.
I want to add, if you're listening, so any other centers in Sindh who want to join us, please let us know. We'll be happy to add as many as we want.
So if there are no other questions, we will just end our presentation with this one slide.
And I want to thank you, Dr. Fiza Jilani, Iftikhar Hussain, and everyone who contributed, Dr. Garland, of course, taking time on this busy Sunday and from your personal time and being here with us. We truly appreciate that. That's a service to humanity, and we all are very grateful for your services. Thank you so much.
Thank you for joining us, and Eid Mubarak, everyone. Eid Mubarak in advance. Enjoy your day and join us next Sunday. Thank you very much.
Thank you very much too. Yeah, thank you.
Thank you, everyone.
So we have participants from Saudi Arabia.